Now let's talk about the relevant physiology for neuraxial anesthesia. Now, in the neural axis, we have the spinal cord, we have the nerve roots coming out, we have an intrathecal space or the subarachnoid space, and we have an epidural space. Both of them contains nerve roots, okay, and some blood vessels. Additionally, epidural space has lymphatics and fat as well, and a good venous plexus. What nerves are contained in the neural axis? We have our sensory nerves, okay, then some nerves are motor nerves, and then we have the autonomic nerves. The sensory nerves will be of different sensations. They could have cold, we have warmth, we have pinprick, okay, we have proprioception, and so on and so forth. We have a lot of sensory nerves. Then we have the motor nerves, which are for the motor activity, the voluntary motor activity. And amongst the autonomic, we have the sympathetic and the parasympathetic. Very important, the sympathetic outflow is from the thoracolumbar spinal cord, but parasympathetic is considered the cervicosacral. Now remember this. Why? Because when we are blocking the nerve conduction in the lumbar, thoracolumbar area, we are essentially blocking the sympathetic. Whereas when we give a saddle block, where we are concentrating all the drug in the conus medullaris, in the sacral supply, the sacral nerve roots, then parasympathetic gets blocked. And both of them have a balance. So if one is blocked, the other will predominate. And this is one of the basic reasons why we have so many hemodynamic uh, events that follow as a consequence of spinal or even epidural anesthesia. Okay, so let's talk about the sensory block that happens. Now, sensory block happens sequentially. Basically, we are doing what? We are injecting local anesthetic, right, into the spinal cord, into the near the nerves, right? This local anesthetic will enter the nerves and it will block the transmission. This is the basic mechanism of action of any local anesthesia, and neuraxial anesthesia is also one form of local or regional anesthesia only, right? So when we are using local anesthetic agent, there is block of transmission. So the characteristics of these nerves really matter on how they behave with the local anesthetic. Any nerve which is myelinated, or I should say any nerve which is unmyelinated or is small in caliber, okay, is more sensitive to local anesthetic. Obviously, because see, if this is an unmyelinated nerve and this one is the myelinated nerve, okay, the unmyelinated nerve, the local anesthetic agent can act on so many areas. And I read it somewhere that I think it's right. I think 1 millimeter cube of volume is required, or basically for a myelinated nerve, it said you need 3 consecutive nodes of Renware. These nodes of Renware, right? If I make one more here, you need 3 of these to be blocked. Only then there will be effective blockade in the nerve transmission. So an unmyelinated nerve is completely exposed, right? So it can block a small area very well, and that will, stop the transmission. But for a myelinated nerve, we have only small areas of exposure where at the nodes of Ranvier, right? That is why an unmyelinated nerve is more sensitive. Why a small caliber will be sensitive? Because any nerve is made of bunch of nerve fibers, right? So a local anesthetic will have to penetrate inside, right, to anesthetize the whole nerve. And unless all the fibers are blocked, the nerve conduction keeps happening. So any nerve which is smaller in caliber, obviously it will be blocked faster than any nerve which is larger in caliber. Based on these two basics, right, different modalities get blocked differently, because their nerve fibers are different. So what happens is that your sympathetic nerves, which are the B fibers, which are small and unmyelinated, being the most sensitive, gets blocked first. This is followed by the cold sensation, which is blocked, and it is supplied by the C fibers, which have more myelination, but they are also small. After this, we have the pinprick, which are thicker than the cold ones, and they are very well myelinated, A delta fibers. Of all the sensations, the last one to be anesthetized is the touch. Okay, because these are very well myelinated, A beta fibers. So we have the autonomic, then we have the sensory, and after this, at the end, we have the motor nerves, that motor conduction, that gets blocked, which is supplied by the A alpha fibers, which are really thick and they are highly myelinated. So these are the least sensitive. Also, they are in the very core, so the drug has to penetrate very deep into the spinal, into the nerves, to block the motor. Now, differential sensory block. What is this differential sensory block? It's very important. It can be asked as a question in your Viva as well. So what happens is, I'll just explain this in one line. Differential sensory block is the difference in the peak block height for each sensory modality. Why? What it really means is, if this is your spinal cord, right? And if I've injected a drug here, here is the maximum concentration of the drug. Now this drug has two places to go. One, it will start diffusing inside deeper and start anesthetizing the nerves at the level I have injected. Another, it will start going up or down. As this drug moves upwards, right, some of it reaches here. At this level, again, there will be some penetration, right? So as the time passes, the the place where I have injected the drug, first the autonomic will be blocked, then the sensory will be blocked, then the motor will be blocked. By the time, like, I'm talking a little hypothetically, okay, just imagine, by the time this drug has penetrated within and has blocked autonomic and sensory as well as motor, some drug has uh, traveled capillary and penetrated the capillary segments. Here, autonomic is blocked, sensory is blocked, but the motor is still left. Okay, then this drug will keep moving upwards, and here it will uh, has blocked only the autonomic, sensory, and motor are still left. Why this happens is because when the drug that is present here where I've injected, it has got good time to penetrate. By the time it is penetrated through the some drug will travel upwards, and then it will penetrate here. So obviously the upper segments or the capillary segments will be a little behind in their penetration within the spinal cord, and so as per their sensitivities, different modalities will be blocked at different times. So at any one point of time, if I will compare the peak block height for each modality, which means autonomic, sensory, and motor, I will find that the autonomic being the first to get blocked, the even at the highest level, like even farthest from the site of injection, autonomic would be blocked. And I would see that the sensory would be blocked two levels behind or lower to autonomic, and motor will be two levels further behind. So look at this one. This is the sensory dermatomes, and these are the myotomes. So at one point of time, as I said, autonomic will be two segments higher, right? Then sensory, and then the motor. So let's just say that if you have seen, right, when we give spinal anesthesia, we ask the patient to lift their leg up. We ask them to do a straight leg raise. That happens because of the hip flexion, and that is supplied by the L1, L2 roots. So if a patient is not able to do a straight leg raise, that means the hip flexion is not possible. That means L1 or L1 is blocked, right? If L1 is blocked and I know about this differential blockade, I know that L1 motor is blocked, right? So sensory T10 would be blocked. Sensory T10 is here. Okay, it's here at the umbilicus. So if the motor L1 is blocked, that means the patient cannot do a straight leg raise. The sensory level must be at the umbilicus, and the autonomic would be even further up, T8 would be blocked. Now your sympathetic system is the thoracolumbar, right? If my blockade has autonomic blockade has reached T8, that means all the lumbar outflow is blocked, and now we are reaching the thoracic outflow as well. So there is to be I have good suspicion that there would be soon a fall in blood pressure because of the block in the sympathetic system. And since I know that the patient cannot do SLR, so the level of my sensory blockade must be T10. The peak block height must be T10, like, which means that if I check at T8, the sensations would still be intact. The patient might feel a pinprick at T8, but not at T10 if the patient is not able to do a straight leg raise. So we need not take a needle and keep on checking. This is how we can predict where the level would be. Although it is always wise to check with a pinprick by yourself before you ask the surgeon or the surgical assistant to check by themselves. Okay, so this is the importance of the differential sensory block. Talk about certain mechanics that take place. First, we'll talk about the drug uptake. Okay, so as I just told you, I took a local anesthetic, and say for example, I gave a spinal anesthesia and I injected in the subarachnoid space. So what happens? Where will the drug go? What are the options for the drug? It will diffuse through the pia mater and it will reach the dorsal root ganglion and the nerve roots. Then it will pass through. When it passes through the dura, it will reach the epidural. Sorry, when it passes through the dura, it will reach the epidural space as well, right? And then if there are blood vessels, some blood vessels will take it up. So there are three things that happen to an LA when I inject it in the subarachnoid space. It will reach the nerves. It will some of it will be lost in the epidural space, and some of it will be picked up in the blood vessels. Now this blood vessels is important because blood vessels are what will take up this drug and will take it to the systemic circulation, and then the drug will be metabolized, and this is how the elimination takes place. I'll come to that later. Okay, this is the part where the main action happens, and this is the part where some of the drug acts slowly because epidural takes time. It is a potential space and the nerves are a little farther out from each other as compared to the subarachnoid space where they are closely compactly arranged. So a lot of surface area is available in a shorter duration and and a smaller space. So some of the drug will keep acting in the epidural space as well. Now this drug penetration and uptake, right? This depends directly with the drug mass. Drug mass, when I say it means the milligram of dose that I have given, the CSF drug concentration, the contact surface area, the lipid content. When I say lipid content, it actually means the lipid content of the nerves. So of the tissues that are available, not just the nerves. So obviously the lipid content of blood vessel is less than the nerves. And nerves have the myelin sheath, which is considered which is very lipid rich, and that is why the local anesthetic will be taken up by the nervous tissue more than it will be taken up by the blood vessels. And this drug uptake is indirectly related to the nerve root size, which I have already explained. higher the caliber, thicker the nerve, the penetration will take more time. Now, local anesthetic CSF concentration is highest at the level of injection, which means that at this point the penetration within the deepest part of the spinal cord at these levels would be the highest as compared to the other levels, obviously because the drug has to spread first to reach the other levels. Okay, here it is present in the higher concentration, so it is able to penetrate first. When I inject a drug in the epidural space, when I take a local anesthetic and I inject it in the epidural space, here again it will work on the nerve roots. Some of it will be picked up by the blood vessels, some of it will be lost in the lymphatic supply, some will diffuse into the subarachnoid space as well. Okay, and then some will be taken up by the fat. Now epidural space has good amount of fat in comparison to the subarachnoid space, and in comparison to nervous tissue, since the lipid content actual lipid is present, some of it will be taken up by the fat as well. So these are the losses of the local anesthetic drug that happen. Also, if it is in the fat, it will be slowly absorbed into the circulation as well, or it could be released slowly into the epidural space as well. Once the drug uptake has happened, we have injected the drug, the nerves have started to pick up. We'll talk about the drug distribution. What factors govern the drug distribution? For a spinal anesthesia in the subarachnoid space, now we have the nerves and we have the CSF. Now understand this, the major drug distribution, the major spread of the drug in any place happens by diffusion. Okay, this is the main diffusion along the concentration gradient. Like it will move from higher concentration to the lower concentration. That is why I told you that in spinal anesthesia, the local anesthetic concentration is maximum at the level of the injection, right? So from there, it will start diffusing in different directions. Also in spinal anesthesia, we have CSF bulk flow. Now CSF extends in the vertebral canal up to the brain. Okay, and this bulk flow of CSF happens because of the longitudinal oscillations of the arteries, because of the pulsation, and it leads to a capillary spread. Like basically the CSF is moving towards the brain so that it can be drained into the arachnoid villi and then metabolized and then reused, right? So the evidence of this capillary spread was seen that when a dye or a drug was injected in the subarachnoid space after 1 hour had passed, some traces of that drug were even found in the basal cisterns of the brain, right? So this helps in the spread of the drug as well. The CSF carries the drug along with it. When I talk of the epidural space, obviously the drug spread is basically governed by the diffusion along the concentration gradient as in the spinal. So the drug will diffuse. Where all can it go? It can go into the subarachnoid space, right? It can go capillary up and down. It can go capillary and it can go caudate. See, this is the spinal cord. We have the pia, we have the dura and the arachnoid, and then these are the relations. This is a epidural space. So longitudinally, it can go up and down, capillary and caudate, and circumferentially, it can go inside into the subarachnoid space and enter the CSF, or it can be lost through these intervertebral, like it will travel along the nervous tissue and it will come out of the intervertebral foramen. It can bind to the fat, and obviously there will be vascular uptake. But here the major force of spread is the diffusion. We do not have the luxury of CSF bulk flow or any bulk flow in the epidural space. Now, what factors affect the drug distribution in the epidural space? One is the small caliber. Obviously, if there is if the epidural space is narrower, there is less space where the local anesthetic has to go. So the spread along the cephalad and the caudate, that is the longitudinal spread, would be uh, faster, right? Then we have if the epidural compliance is high, because it's a potential space. So if it's a roomy cavity, then the spread is easy. If the epidural fat content is less, obviously then there is more for nerves. So again, the spread would be easy and faster, or the effect will come faster, right? Then if there is reduced leakage from the interventricular foramen, which happens in cases of spinal stenosis or in elderly patients where the interventricular foramen also has reduced lumen. The leakage through this foramen is less, so the drug distribution within the epidural space will be more. Then, if the epidural pressure is high, as in cases of ascites or pregnancy, obviously that would lead to a rapid and a better spread within the epidural space. If I compare different spinal levels, if I am injecting a drug, okay, so if I am injecting a drug in the lumbar area, okay, the drug will have a tendency to go cephalad, lumbar as well as the lower thoracic. So the lumbar and the lower thoracic, they have a tendency that the drug will go up cephalad, blocking further more segments. But if I have injected it in higher thoracic level, it has a tendency to go caudate, which means what? If you make a patient lie down, in lying down position, you will see that the natural curvatures, right? This is the cervical, this is thoracic, this is lumbar, and this is sacral. The natural curvatures themselves make it happen that the lumbar and the lower thoracic will make the drug go upwards cephalad, and the upper thoracic will make it go caudate. That is why high spinal doesn't happen so easy. I know the traditional conventional techniques have some people putting in pillows below the patient's thorax. Problem with that is you often this curvature, you often compromise this curvature. This curvature actually comes at T4. So if you don't do anything, if you don't do any head down or head up, or if you don't put any pillow and you just make the patient supine in neutral position but supine, the drug will automatically accumulate at T4. It will not go up so easily unless by diffusion. Okay, so now we will talk about drug elimination. How does the drug get eliminated? Now, we had given the drug, it was taken up, right? There was uptake of the drug spread to different levels, it blocked, and now the drug has to eliminate, has to leave the neural axis. So that basically happens by the vascular uptake. The blood takes up the drug, takes it away to get metabolized. As the concentration of the local anesthetic in the epidural or the spinal space reduces, the block in the transmission, that also reduces, and hence there is a phenomenon of regression of block. Regression of block basically means reduction in the block height. So say I gave a subarachnoid block at the level of L3, L4 space, and I allowed it to ascend up till T10 sensory level, which means the umbilicus is blocked. Now, when the drug will start to come out or leave the space, there will be regression, and the regression takes place in the opposite direction. So the first T10 would be free of any transmission and will regain the sensations, then T12, then L2, and so on and so forth. So what are the factors that govern this regression of block? Firstly is the in spinal, okay, is the CSF volume. The CSF volume is indirectly related to the time of regression, which means what? If the CSF volume is low, the time of regression will be more. That means that like time to for this reduction in the block height would be more. In other words, the duration of the blockade, the duration of action would increase. So the spinal will go on for a longer time. So we might not have to give a lot of drug dose in such a situation, because we know a smaller dose would give me a peak block height for a longer time. Where does this happen? This happens in elderly, where the CSF volume is low by their own physiology. Another factor that governs it is the distribution of the local anesthetic. Basically, if I injected 3 ml of drug and I made it to get exposed and block and give me a peak sensory block height up to only T10, as compared to where I have blocked up till T8, obviously the regression will take longer when I have blocked more number of, or where the local anesthetic is spread on a more surface area or more number of levels. Why? Because then this local, now this drug is exposed to blood vessels of so many levels. Okay, so this absorption also increases. So if the drug is distributed to a larger area, the time of regression would be less. So it is indirectly proportionate to it, which means what? The duration of anesthesia would be less. That is why when we have to anesthetize the whole abdomen, that means I want a blockade up till T6, T4, I need to give a larger volume so that the elimination does not happen very quickly. Firstly, I need drug volume enough that it would spread to so many segments and block the nerves, penetrate the nerves adequately. Secondly, I want the surgery to go on for a certain duration. And if I am giving a smaller volume and then I'm making it distribute to more than it can handle segments, then obviously the regression will happen faster. So that is why if you have to block more number of segments, you have to give a larger volume.